Welcome, everyone, and thank you so much for taking time out of your day to join us. My name is Rachel Mayo, and I'm the Outreach Coordinator for JDRF Tennessee. I've also lived with type 1 diabetes for over 15 years, and I'm so excited to have the opportunity to share this valuable information with you, as I personally know how important this topic is to our community.
And I'm Mary Lynn Hsu. I'm the Executive Director for JDRF in Tennessee. And I've been living with type 1 for almost 35 years now. So this topic is certainly of interest to me and my family. Thank you so much to everyone who submitted questions ahead of time. We're so grateful for your collaboration with us. Justin, we're so grateful to have you. We have a long-standing partnership with Vanderbilt that is so wonderful, and we think you are the best. And so excited to have you on the line here with us to help us answer some of these questions. We'll have Justin give you all his credentials, but he is a pediatric endocrinologist at Vanderbilt and an all-around awesome guy. So we're super excited to have him. And Rachel, thanks for moderating for us today.
Well, you're so welcome. And yes, thank you, Dr. Gregory. You are so amazing. I can't wait to have everyone be introduced to you. Before we get started, we want to make sure everyone knows that while we may be in Tennessee, we understand that people all over the country are watching, which is so exciting. This information is valuable for everyone, no matter where you are. A little later, we'll share some resources on what is being done about prioritizing the vaccine for people with type 1. With that, Dr. Gregory, I'll let you introduce yourself and talk about the important study you recently published.
Oh, thank you, Rachel. Yes, my name is Justin Gregory. I'm one of the pediatric endocrinologists here at Vanderbilt University Medical Center. I myself have had type 1 diabetes for 20 years now. And it's an honor to get to take care of patients who have the same medical condition that I have. And I also am a scientist. I do research on type 1 diabetes. So it's wonderful to be here. And I'm excited to share the research that we've been doing here at Vanderbilt, looking at COVID-19 outcomes in type 1 diabetes. If you would, let's just rewind back to March for a moment. Back in March, we had been learning some things about COVID-19 that initially started in China. It was in the news as being really bad in Italy. And then next thing we knew, it was spreading in Seattle. And from an early point in the pandemic, we knew that people with diabetes, broadly defined, were at increased risk for having bad outcomes. But a lot of diabetes in the United States is type 2 diabetes. And in those early studies where they said, hey, there's some concern that a lot of the people who are winding up in the ICU with severe COVID-19, a lot of those people were type 2 or had type 2 diabetes. So I really had a burden in my heart that we would need to have more information about people specifically who had type 1 diabetes. And so back in late March, I started calling up some colleagues of mine here at Vanderbilt and said, I really want to know a little bit more about what happens to people if they have type 1 and they get sick with COVID-19. How much more likely are they to get really sick from COVID-19? How much more likely are they to get hospitalized with this condition? And so what we did is we designed a study where we would identify everyone at Vanderbilt who had COVID-19, and we would categorize those people based on whether they had no diabetes at all, type 1 diabetes, or type 2 diabetes. And every 2 weeks, we would look and see who got COVID-19, and we would wait 2 weeks to see how sick they got. Did they require hospitalization? If they wound up in the hospital, would they need oxygen support? Would they have to go to the ICU? Would they even die in some cases? And so this is what's called a prospective cohort study. The prospective means that you're looking at what's going to happen going forward in time. So once you get COVID-19, you have 2 weeks for an outcome to happen. And so we did this beginning in March and going all the way up through August. And what we found was that people with type 1 diabetes were about 3 times more likely to get really sick from COVID-19 or to be hospitalized from COVID-19 compared to people who didn't have diabetes at all. And we did some statistical adjusting to say, okay, we're going to take into account other factors that might also make you get really sick from COVID-19. Things like how old you are, or maybe whether or not you are a smoker, or whether you had obesity or things like that. And so when we took those other factors into effect, we found that if you had type 1 diabetes, you had about a 3 to 4-fold high risk of getting really sick from COVID-19 compared to someone who did not have diabetes, where all those other things that can make you get sick from diabetes were maxed, were made the same. What's interesting about that is we found that people with type 2 diabetes also had a very similar risk. Those individuals were also about 3 to 4 times more likely to get really sick from COVID-19 compared to people who didn't have diabetes at all. So that was one of the big key findings from our paper. And I think another thing that was really important about the study that we did and that we published in a journal called Diabetes Care was that people with type 1 diabetes have certain risk factors that increase the chances of them getting COVID-19. And a lot of times are getting really sick from COVID-19. And a lot of times we think about, well, glucose control. How good is your A1C, or how close to target is your A1C? And certainly we found that the higher your hemoglobin A1C was, the more likely it was that you would get hospitalized or get a really sick illness with COVID-19. But we did not find that people who had hemoglobin A1Cs that were in target, or that were where you want them to be, we did not find that their risk was the same as someone who had no diabetes at all. In other words, even if you have glycemic control, glucose control, it's where you want it to be with type 1 diabetes, you still are at increased risk compared to someone who doesn't have type 1 diabetes at all. And that was a little bit disappointing to me, I guess, from when I think about the emotional side of myself that has type 1 diabetes. I wanted to be able to say, well, if your glucose control is right at target, you don't have any increased risk. And that's not really what our research found. We found that there's still some increased risk, even if your glucose control is where you want it to be. We also found that factors that I would call non-medical factors, things like your race and your ethnicity. We found that your socioeconomic status, things like, did you have public insurance versus private insurance versus no insurance at all? We found that many of these factors that aren't purely medical factors also played into, or at least were strongly associated with being more likely to get sick from, or get really sick from COVID-19 or requiring hospitalization. So I think, and some of these questions that we'll talk about, we'll discuss this some, but I think the practical application of this information is not to say, okay, I'm going to live in a cocoon until the pandemic is over. I'm not going to send my kids to school. I'm not going to participate in anything outside. I'm just going to stay inside the whole time. I don't think that's the message that this research says. This research says that all the things that everyone should be doing, whether it's social distancing, hand washing, wearing a mask, avoiding large crowds, especially inside, I think that people with type 1 diabetes need to be doing that to a very high level. I think that that's stuff that anyone should do, whether they have diabetes or not. But I think that people with type 1 should lead the way in doing those things. And then I think some of what we're going to talk about in a minute is, I think that indicates that people with type 1 diabetes need to prioritize having a vaccine against COVID-19, given that these vaccines are so effective in preventing developing COVID-19. So that's just a quick and dry of our study. Rachel, I'll turn it back over to you at this point.
Thank you, Dr. Gregory. We are so appreciative of the work you've done and continue to do to provide this information to our community. And we've received several questions regarding COVID-19 and type 1. So if you're ready, we'll go ahead and move to some Q&A.
Let's do it.
All right. First question is, have you received more data since you published the study, and has it given you any additional information?
Yes, we've continued to gather more data since we published the study. And what the data show, the biggest things that the data show is that they reinforce our earlier message. The more people we get, this ratio that I keep talking about being 3 to 4 times more likely to get really sick from COVID-19, that's only being reinforced. And the more patients we get, the more we're able to look not just at the entire group of patients with type 1 diabetes, but more specifically at different subcategories of people with type 1 diabetes. We are looking at what happens in younger patients who might be less likely to get severe illness because of their young age. We're looking at people who I mentioned earlier who have good glycemic control. And we're finding that, again, this message of, yes, the things that are protective if you don't have type 1 diabetes are protective if you do have type 1 diabetes, like someone who's 20 and has type 1 diabetes is less likely to get really sick than someone who's, say, 70 and has type 1 diabetes. But it's really hard to get people with type 1 diabetes, at least statistically speaking, to look like someone who doesn't have diabetes at all. Whether you're young, whether you have good glucose control. So it's this message that we keep coming back to, that the things that make you healthy still make you healthy. It's just hard to take that type 1 diabetes away in terms of risk. So.
Sure. Thank you.
Yeah.
Okay. What changes in sugar levels and A1Cs are type 1s with COVID experiencing during and after active illness?
Yeah. So it's a very good question. So far, we don't know, no one's done a study to look and see what happens to blood sugar levels specifically in people with type 1 diabetes. So we're going to have to extrapolate a little bit to answer that question. And I'm going to extrapolate from 2 places. The first is people who have type 2 diabetes or no diabetes at all. We find that among people who are really seriously ill with COVID-19, people in the ICU, we found that those individuals, about half of them have higher than normal blood sugar levels. Okay. And what I think that means is that when you're really sick from COVID-19, the hormones in your body that cause the blood sugar to go up are really working hard to cause the blood sugar to go up. And not only that, they're causing people to be resistant to insulin. So I extrapolate a little bit that people with type 1 diabetes are probably going to see an increase in their blood sugar levels when they get COVID-19, although I can't point to a study that's looked at that yet because I don't know that there is one. And then I'm going to extrapolate from the second place, which is other viral illnesses. We have a lot of experience, and certainly in pediatric endocrinology, that says when someone gets sick with a virus and fever or they're throwing up, that blood sugar levels tend to go up in those individuals. And the reason that happens is because, again, those same counter-regulatory hormones that are normally great if your blood sugar is low, they're not so great if you're sick, because that tends to make the body make its own glucose. So glucose is coming out of the liver into the blood. And when you're sick, you tend to see the blood sugar levels go up. Now, if you don't have diabetes, your body can say, all right, I'm going to just make more insulin. I'm going to bring those glucose levels down by making more insulin. But when you have type 1 diabetes, you don't have the luxury of making more of your own insulin. You have to do that on your own. So right now, to summarize, I think we will find when someone does a good study of this that blood sugar levels go up in people with type 1 diabetes when they get COVID, but we don't know that for sure right now.
Sure. Thank you. Is there a higher risk for teenagers with type 1s than others for severity of symptoms?
Yeah, so we're actively looking at this question, and we're trying to see, okay, if you have type 1 diabetes, how much more likely are you to get really, really sick from COVID-19 compared to someone who doesn't? And so far, we don't have evidence that says the severity of COVID symptoms, things like shortness of breath, fever, and really serious things like heart disease or pneumonia. I don't have evidence that says, hey, if you have type 1 diabetes, you're much more likely to have COVID-related illness.
Mhm.
What I'm interested in and what we're trying to gather data in is the question of, if you have COVID-19, are you more likely to wind up in the hospital because you might be more likely to get diabetic ketoacidosis? One thing that people with type 1 diabetes are prone to that people without type 1 diabetes are not prone to is diabetic ketoacidosis. And so as this study goes by, that's a question we're really, really looking at. So when I think about a patient who's a teenager with type 1 diabetes, we already know that teenagers who have type 1 diabetes, even aside from COVID, are more likely to get DKA than older patients who have type 1. So I think it's important for teenagers that get COVID-19 to really be on the lookout for DKA. So it's important to know what most endocrinology doctors will have diabetes sick day rules that you're supposed to apply when you get sick from any illness. It's important to know what those rules are. That way, if you do get COVID-19 and you have type 1 diabetes, you can have sort of a plan in place to decrease the likelihood that you're going to get really serious DKA.
Mm-hmm. Okay, thank you. Now, this next question we received a ton of with the pre-submitted questions, but also just in general over the last several months.
Sure.
There an increased risk of susceptibility to the virus for people with type 1 versus the general population?
Yeah. So we've already established that once you get COVID-19, you're at increased risk from having severe illness.
Mm-hmm.
But the question is out there, well, how are you, all other things being the same, is someone with type 1 diabetes more likely to get it in the first place? So far, we don't have any evidence to point to that says you're more likely to get sick. I think there's this idea that, well, if you have an autoimmune condition, maybe you're more prone to getting a viral illness. I just don't see much evidence of that being there in the literature at all, and more specifically with COVID-19. I would look to ongoing research to maybe help answer that question, yes or no. But so far, we don't see any evidence that you're more susceptible to getting COVID-19 if you have type 1.
Okay, well, that's good news at least.
Yeah.
Okay, we have one more question, and it might be a little complicated, but we have been seeing an increase in type 1 diagnoses over the last several months. Do you think that there is a link between contracting COVID and then later developing type 1?
That is a very hot topic in the research arena right now, and it's one that my colleagues at Vanderbilt have actually been addressing. I'm going to answer that question. I think I'll try not to get too science classy here, but I think it's helpful to understand where the question is coming from. And I'm going to show you all a picture of the coronavirus here. Okay, so this is coronavirus. And the reason it's called corona, the corona and coronavirus, corona means crown. And if you sort of look at a cross section of the virus, it kind of reminds you of a crown a little bit. At least some people would say that it does. Well, there's this protein that's right here on the surface of coronavirus. It's called spike protein. Okay. And spike protein has an important job if a SARS-CoV-2 virus is going to be successful in causing COVID-19. That spike protein, to get into a cell, has to bind to another protein on this target of whatever cell it's trying to get into. A lot of times we think about lung cells. That protein that the spike protein is trying to bind to, like that, is called ACE2. Okay, and for now we won't bother with what ACE2 does. We'll just keep in mind that ACE2 is the virus, or is the protein that's on top of our own body cells that the virus uses to get into the cell to replicate and cause the infection to happen. And so early on, people said, hey, there's a lot of case reports of people coming in with new onset type 1 diabetes and they have COVID. Could it be because of something going on between SARS-CoV-2 and the beta cell that makes insulin. And so my colleagues here at Vanderbilt, including Katie Coate and Dr. Al Powers, who has been a mentor to me for a long time, they looked at this question. And what they found was that ACE2 protein that's needed, or at least we so far think is needed for the virus to get into a cell, isn't on a beta cell. And moreover, a cell that sort of chops up that spike protein so that the virus can get activated inside the cell, that other protein that's needed isn't there inside the beta cell either. So it doesn't look like the virus is directly invading a beta cell, killing off the beta cells, and now, oh, I don't have beta cells, I can't make insulin, I have type 1 diabetes. I don't see evidence of that. Now, it's possible, and ongoing research is going to have to address this question, that there could be sort of an indirect thing that happens. So it doesn't go into the beta cell, but perhaps it goes into cells that are near the beta cell in the pancreas, things like there's a cell called pericytes. And maybe inflammation in that part of the pancreas causes sort of an indirect hit to the beta cell. That question hasn't really been fully fleshed out yet. My own somewhat informed speculation is that it's not the SARS-CoV-2 virus itself. A lot of time, we know a few things about people who come in with new onset type 1 diabetes. We know, for one thing, that it's more common for people to come in with new onset type 1 diabetes in the winter. And it's helpful to think about the process that you have to go through to get diabetes. It takes months in most people to go from the point where their immune system doesn't like their beta cell anymore. So your immune system's attacking your own beta cell to the point where you start out with like 100% of your beta cells, and you lose so many beta cells that you can no longer make enough insulin to maintain normal glucose level. That process takes months. You got to go from about 100% of your beta cells to somewhere down around 10% of your beta cells before you'll start seeing glucose levels go up and having symptoms of high blood sugar, like you're peeing all the time or you're thirsty all the time. One thing that can hasten that process is getting sick. And it may not be specific to getting sick with COVID-19. It may be you get sick with the flu. It may be you get sick with just something beyond a cold, like a stomach bug. And then all of a sudden, you were able to get by and maintain normal glucose levels with 10% of your beta cells. But now your body's, again, making all those counter-regulatory hormones go up. And those 10% of the beta cells that are left simply can't do the job anymore under the stress of the illness. So I don't necessarily at this point think that it's COVID-19. That's my speculation. As much as it is, we have a huge pandemic where lots of people are getting sick with COVID-19. And that's what, again, just the fact that you're sick with something says, hey, my beta cells can't keep up anymore. But all that said, this is a highly controversial area of research that's ongoing right now, but that's my own informed speculation about that question. Sorry for the long.
That is great information, and I learned something too, so that's awesome. Thank you so much for sharing. Now we want to kind of shift to the subject of the very exciting newly available vaccines, which we have a ton of questions about.
Yeah.
So Dr. Gregory, if you will just please explain what you can about these two vaccines.
Well, Rachel, I'm very excited about the two vaccines that have been approved by the FDA in the United States. They're both called RNA vaccines. And just as a quick overview, a lot of people are like, well, what is RNA? The way to think of RNA is it's like an instruction manual that tells a cell to make a product. Okay, so an RNA vaccine, you give an injection into the muscle of, normally it's the deltoid right up here, and that RNA that's in the vaccine goes into a muscle cell. And so again, the RNA is like an instruction manual, and it goes to what I would say is the muscle cell's factory. It's called the ribosome. And so the instruction manual goes to the ribosome and it tells the ribosome, hey, make this spike protein that we're talking about. It's the protein that's on the surface of the SARS-CoV-2 virus. And so the muscle cell said, okay, I'll make this spike protein. So it makes the spike protein, and your immune system says, hey, I don't recognize that spike protein. And so your immune system says, I'm going to get rid of that spike protein. And not only that, I'm going to remember the spike protein. That way, the next time I see it, I'm going to go to war on it. I'm not going to let it cause an infection at all, or maybe if it causes an infection, it won't be as severe as had I never seen the spike protein before. So that's kind of just a quick look at how the vaccine works. I'm excited about the vaccine because it's been shown in the Pfizer and in the Moderna studies to be highly efficacious. You're talking about upwards of 90% effective in preventing becoming infected with SARS-CoV-2. And an important comment that I have about that is that there were a large number of participants. I want to say in each study, 13% of the participants had diabetes. Now, in the reports, they don't tell you whether it was type 1 versus type 2, but nonetheless, we can say that a lot of people with diabetes were in that study. The Moderna trial had something of around 30,000 participants. The Pfizer trial had about 40,000. And so a lot of people with diabetes were in the study. And one of the reasons I'm excited is that not only was the vaccine very efficacious in preventing someone from getting COVID-19, it was just as efficacious in people with type 1 diabetes. So it's a highly effective vaccine. And I would say that the side effect profile is pretty good. It's the side effects that we see with this vaccine are comparable to side effects that we see with vaccines that we're already using pretty commonly, like the flu vaccine, for instance. So I'm excited about the vaccine itself. I'm specifically excited that it's going to help people who we've established have an increased risk of getting really sick from this virus. It's going to help those people not get the virus in the first place.
Dr. Gregory, I know that you've personally received the vaccine as well. Can you tell us a little bit about your personal experience getting vaccinated?
Yeah, so I was actually a participant in the Moderna study that was done here at Vanderbilt, led by my colleague and friend, Dr. Buddy Creech. And when I heard about the vaccine study, I really thought it was important that people with type 1 participate so we can have some idea of what to expect. And so I'll tell you kind of my experience. With the Moderna vaccine, you get two immunizations. You get the first, day 0, and then 4 weeks later, you have a booster. Now, with the first vaccine, I had just a small little rash near where my injection was. I had some lymph nodes that I could feel in my armpit that were there the next day, and they were gone 48 hours later. So pretty mild side effects there with the first dose. With the second dose, I was in that group of maybe 1 out of 10 to 1 out of 6, at least in the Pfizer study, of people who had a fever. I had a fever with the immunization, had chills that night, had headache, muscle. And so, I had symptoms myself. I wound up taking ibuprofen, and it was very, very helpful. So that's anecdotal. That's my experience. More broadly speaking, I think people are wondering a lot about, well, what's the likelihood of getting really sick from this vaccine? About 50%. The two most common things that people reported in the Pfizer studies, what's in front of my head right now, was about 50% of people said they were fatigued in the 48 hours after they had the vaccine. But it's worth noting that people who received placebo, 25% of them said they were fatigued during the 48 hours. So really more fatigue, but everybody's fatigued. So that was one thing. And then injection site, about 70 to 80% of people said, yeah, this kind of hurts my arm. So those are the two most common things. I mentioned that fever in the Pfizer study happened between 1 out of 10 and 1 out of 6 people had fever and similar things like chills and stuff. And that's pretty comparable to other vaccines that are out there, more broadly speaking. So I think when I think about the known risk of COVID-19 versus this fairly small risk of having symptoms that are gone within 48 hours in most people, I feel like that's a pretty favorable risk to benefit differential in favor of the vaccine for people with type 1.
Sure. One of the most common questions we had is length of immunity. Once you get the vaccine,
Yeah.
how long does it last?
Yeah, that's a great question. So the best data I can draw from is people who were in the Moderna trial, who are in the phase 2. There's 3 phases of clinical trials. Phase 2 is where you're trying to get some idea of safety and starting to get ready for more broadly studying big groups of people. So people who are in the phase 2 study that came in the summer of 2020, they published a study in the New England Journal of Medicine that showed that those guys, up to going 4 months into the phase 2 trial, still had pretty high levels of what they call neutralizing antibodies that are protecting you against getting SARS-CoV-2. So far, time's going to have to pass to be able to answer the question of durability of protection from the immunization. But it's pretty encouraging, actually, to see that 4 months after the vaccine, people are still having measurable antibody levels. So I think there's room for some optimism there.
Yeah, well, that's great. I had a couple questions submitted about I'm this age or I'm that age, or I was diagnosed at this age, I was diagnosed when I was an adult. Do you suggest getting vaccinated for just across the board, no matter when you were diagnosed, no matter your age now? What is your suggestion there?
Yeah, so my suggestion is that if you have type 1 diabetes and there's no contraindication for you having the vaccine, you should get the vaccine. So right now, that does not include individuals who are below age 16. It hasn't been, the Pfizer vaccine is, I think, approved. I might get it mixed up here. I think Pfizer is for age 16 and up, and Moderna is for age 18 and up. The studies are ongoing now in adolescents, like there's an ongoing Moderna trial for ages 12 up to 18 to try to see if we, to assess the benefit or risk to benefit profile for those people. So hold on, all you guys who are below age 16. But I think these data suggest that if you're age 16 or higher and you have type 1 diabetes, regardless of when you were diagnosed, I would recommend getting the vaccine, knowing what we know right now. Certainly, I don't. And one thing that's important to say is that I don't want to supplant the advice of each person's physician. I'm not trying to substitute for them, but if I'm speaking to a broad group of people, I think that this risk to benefit profile favors immunizing. And so even if I wasn't in the Moderna trial, I would be trying to get immunized as quickly as I could, just because I think the risk in type 1 is higher.
Sure. We did have a lot of questions about kids being able to get the vaccine. Is there any indication of when kids under 16 might be able to be vaccinated?
Yeah, I wish I could give you a better sense of as to when those studies will be complete. I want to say that the Moderna trial, the pediatric trial I mentioned in age 20 or 12 to 18, I want to say that they're 4 weeks into that study right now. I think they're looking to recruit somewhere on the order of 3,000 participants. I don't have that information right in front of me. And so I think, and this is, I'm not sure about this, but I'm thinking that they're hoping sometime by the summer that they'll be able to go to the FDA to get what's called an emergency use authorization to give the vaccines to kids. But right now, we don't know when it's going to be approved in younger people below 16. And in my own mind, for whatever that's worth, I'm hoping for summer, but we just don't know for sure yet.
Related to that, we've had a couple of questions about trials for kids. Do you know of any studies where kids can get into if they're interested?
Well, a good place to look to see what trials are available out there is a website called clinicaltrials.gov. And so you can go to clinicaltrials.gov. You can search for COVID-19 trials, and you can search to see where those trials are being done. And oftentimes when you go in there, it'll say what sites are available, and if there's a site that's near where you live, usually they have a contact number or an email address that you can reach out and get some more information about the trial.
Great, thank you. Dr. Gregory, we've had a few people ask, I've already had COVID, so do I even need the COVID vaccine?
Yeah, it's a great question. And that's one that we're getting a lot. So first of all, the question of should I get vaccinated if I've already had it, what that speaks to is, well, my body's already gotten rid of the actual virus. I've already made antibodies. Do I need a vaccine at all now? Because I've had the actual virus. Well, it turns out that we recommend, the CDC recommends, getting vaccinated even if you've already had COVID-19. And the reason for that is that there's some thinking among experts in the field that your duration of being immune to the virus is actually better with the vaccine than with the actual virus, which that may seem kind of like, boy, that seems counterintuitive. It seems like the virus would cause a more robust immune response, but there's actually some precedent for this, and with a virus called pneumococcus that causes pneumonia. Turns out that we know from experience with the pneumococcal vaccine that the duration of immunization or being immune to that bacteria that causes pneumonia is actually longer from the virus than it is with the actual illness. So there's some precedent there, and so that's some thinking among experts in the field, is that even if you've already had the virus, the chances of you getting the virus again are even less likely if you go ahead and get an immunization afterwards. Now, then the next question is often, well, how soon should I do this?
Literally my next question.
Right. Well, certainly you don't want to go out any more soon than your quarantine period is. And so, and you can talk with your doctor about how long you're supposed to stay quarantined once you have the virus. But the CDC says it's okay to get the immunization at any point after that quarantine period is up. I think it's also okay to have a conversation with your healthcare provider about saying, hey, do I need to do this right now? There's some evidence that you're unlikely to get COVID-19 again for 90 days after you've had an infection. So I think it's also reasonable to say, well, I'm going to, not rush getting the immunization until that amount of time's gone by, and then do it. And like with many things, I think it's always a good idea to bring it up with your physician and ask that question. But those are my thoughts about that question.
Sure, thank you.
Sure.
One of our other questions is one of the vaccines preferred over the other for people with type 1?
Yeah, there's no data to speak to that question. And a lot of times it isn't even a luxury you have. A lot of times, if right now anyway, it's if you have the Pfizer or the Moderna vaccine, it's either that or nothing. So I would recommend just getting what's available to you. But certainly there's not been any head-to-head studies at all looking at whether or not the Pfizer or the Moderna vaccine is more effective. There's not been any head-to-head studies saying that to inform whether one is better than the other for people with type 1.
Okay, great. Our next question is, I have heard that the new COVID-19 vaccine could trigger more autoimmune diseases like lupus or other autoimmune diseases if you already have an autoimmune disease like type 1. Is this true?
Well, it's a good question. To break that down, let's first of all talk about what we know and what we don't know. Okay, so right now, what we know is that if you have type 1 diabetes, your chances of getting really sick from COVID-19 are higher than if you don't have type 1 diabetes. That's the first thing. The second thing that we know is that this vaccine, which was tested in a lot of people with diabetes, is highly efficacious in protecting against getting the vaccine. So far, we already know a year into this that, yeah, the risk of getting COVID is high and the protective effect of the vaccine is very favorable. Those are the things that we know. Now we come over into the things that we don't know. We don't know, is there any chance that this can increase the likelihood of getting another autoimmune disease? And we don't know that because that hasn't been, this is a new virus. It hasn't been researched. So I think we need to think about how likely that is. First of all, people with type 1 diabetes have been getting immunized against other viruses for years and years and years. And we've never seen any indication that our experience with things like the flu vaccine or other vaccines increase the likelihood that you might get another autoimmune condition. So with that knowledge, we can't specifically speak to the COVID-19 immunization, but we can extrapolate a little bit that seems unlikely with the COVID-19 immunization as I think about it. Second, it's helpful to compare what happens if you actually get COVID-19 versus if you get the immunization as it relates to the potential for getting an autoimmune condition later. Because chances are, just given how much COVID-19 is out there, if you don't get immunized, there's a decent chance you're eventually going to get COVID-19, I think. So let's compare what happens if you get COVID-19 against if you get the RNA vaccine. All right, if you get COVID-19, again, that virus goes into your cells. It hijacks that ribosome I talked about that makes the protein. So the virus goes in there. It tells the ribosomes to make all those proteins that become more virus, things like spike protein and everything else. And those proteins go out into your body. And your immune system sees those, it fights them off, and hopefully, pretty quickly you get over it. So your body is exposed to proteins in the virus, and your immune system reacts against those. Now let's compare that against if you get the vaccine. There, RNA comes into the muscle cell. It tells the muscle cell to make just one protein, spike protein, in what we call a non-binding form. So it's a spike protein that won't bind to anything. It goes out into the body. Your immune system sees that. It responds against that spike protein. And hopefully the next time your system sees spike protein, it fights it. So in either case, either getting the vaccine or getting the virus, your immune system is being exposed to spike protein. And in the case of the actual virus, I think 28 other proteins as well. So the incremental risk for autoimmune disease between getting the actual virus and getting the immunization is in my thinking must be pretty small. So again, to kind of sum, I'm going to mainly focus on what I know, which is risk of COVID is high, benefit of vaccine is highly beneficial. And then when I even get into what I don't know, as I think about it, the likelihood of this causing other autoimmune conditions seems small. Some of that's speculative on my part, but that's how I think about the question.
Okay, great. Thanks so much for sharing your thoughts on that.
Sure.
Well, this has been such great information, but the main question is, how are people with type 1 being prioritized when it comes to getting the vaccine?
Well, yeah, the answer is kind of complicated. So right now, the CDC makes recommendations on how individual states will prioritize the vaccine rollout. And broadly speaking, I think most states prioritize in what often is called phase 1A, people who are healthcare workers who are being exposed to the virus more often, who need to be working in the hospital to take care of people with COVID-19. That's high up on the priority list. And also people who are living in congregate housing. In other words, people who are living in close proximity to each other, who are more likely to get sick because they're just living around other people, and often are more likely to get really sick if they do get COVID-19 because of old age. So things like assisted living facilities come to mind. So that immunizing there has been ongoing around the country since December or January, I guess, since the past few weeks. Sort of the next level is people who are helping to keep the trains running in our country. So people like policemen, firemen, school teachers, they're kind of at a lot of times what's called phase 1B, and that's ongoing in a lot of the country too. Now, where the rubber hits the road is what's called phase 1C, at least in my state, in Tennessee. And that's what are people who have high-risk medical conditions. Now, who gets included in high-risk medical conditions is a little bit up in the air. Okay, right now what happens is the CDC makes recommendations to individual states as far as who is at increased risk, who goes in that group. Now, at present, the CDC says that people with type 2 diabetes and other high-risk conditions like sickle cell disease, heart disease, increased age, people in that group are considered high risk. They say people with type 1 diabetes might be at increased risk. Okay, so that's kind of in a category where they say, we don't know that there's enough evidence to say that they are at high risk, so we're going to say that they might be at increased risk. Now, I'll add my commentary that I think that needs revision. I think the data that we've talked about says, hey, there's no might be about this. People with type 1 diabetes should be in that high risk category. That's my interpretation of the data. Okay, so that recommendation from the CDC is then given to individual states to help the individual states determine who does and does not go in that high risk category. So some states like Tennessee say, okay, it doesn't matter whether you have type 1 or type 2 diabetes. If you're 16 years or older and you have one of those high risk conditions, including type 1, you're in that phase 1C. Other states have not done that. Other states have not put people with type 1 diabetes in that high risk condition. So this is fluid. Other states may do what Tennessee does. That's what I hope happens. But in my state, we're hoping that people with high risk conditions will start being immunized in March. That's the goal that our state set. And I imagine other states have similar goals. So I guess to answer that question, that's how prioritization is working. It's a fluid, dynamic process. I'm hoping that other states and that the CDC will revise those guidelines to put people with type 1 diabetes in the same category as people with type 2. So that's kind of where things stand with vaccine prioritization, right?
Okay, great. Thank you. Mary Lynn, if you could join us again, because we've had so many questions about what can people do to help get their state on board with prioritization. So if you can talk a little bit about what JDRF has been doing about vaccine prioritization for people with type 1.
Absolutely. Well, like Justin said, and like his study shows, COVID-19 is taking a significant toll on the type 1 diabetes community. And so this matters a lot. Those CDC recommendations, that's where we've started. That is like the highest level, where if we could get that to change, that would help maybe sort of automatically change the decision-making in some of the states. So what we've done there, we've submitted formal recommendations using Dr. Gregory's study as what we're pointing to for why this needs to be different, that people with type 1 need to be in that same category. And we are hopeful that that will change. What we do know is that those CDC recommendations are not static. So they have been making tweaks to that. I think as recently as end of December, there have been changes. So we feel like there's still a good amount of hope that there could be a change there at the CDC level. In addition to those formal comments that we submitted back in December, JDRF has also partnered with other diabetes organizations and actually submitted a letter to the CDC just this week, again, re-emphasizing how much this matters, how much we need them to have their eyes on this. And then we've been utilizing the sort of informal channels as well as those formal channels. So just people that we know, friends that we have at the CDC, we're reaching out to them individually, trying to help them to understand the data and why this matters so much. We're so pleased that Tennessee is among the first couple of states to recognize people with type 1 in that 1C prioritization category. As of right now, we know, in addition to Tennessee, Ohio, Virginia, and California, and hopefully even as we're talking right now, others are coming online. Like Justin said, this is super fluid. It's changing quickly and changing over time. So what we recommend in terms of what you can do, first of all, if you're not already signed up as a JDRF advocate, please do that. Go to jdrf.org, sign up as an advocate. That is where you can be involved in an ongoing basis in all of our advocacy efforts. On the vaccine prioritization specifically, it does look really different state to state. So we would recommend that you reach out to your local chapter and see what they have in place. We have grassroots advocacy volunteers all throughout the United States that are working on this. So you can come alongside them and help them. But the best way to stay up to date on the list of states that have come online with prioritizing type 1. We have jdrf.org/COVID vaccines. And so that has a whole bunch of FAQ stuff on there. A lot of stuff you've heard from Justin today, links to his study, but also we'll keep updating that with the states that come online as we go.
Thank you, Mary Lynn, and thank you all so much. You all had some awesome questions. Thank you for submitting them. Thank you for participating. And thank you so much, Dr. Gregory, for answering and taking the time to address the questions of our community. Do you have anything else you'd like to address before we close out?
Well, I first want to say thank you to both of you and to the JDRF. Thank you for your advocacy. Thank you for supporting the research that we do as physicians and scientists in type 1 diabetes. And looking back over 2020, one of the lessons that really sticks out in my mind is the importance of working together as a team of people with type 1 diabetes. When I think about my research team, the people that worked alongside me on the research that we just did, nearly half of the people on that who worked on the project had type 1 diabetes themselves. When I think about other researchers who are working on this, like people in the United Kingdom who've done great research on this topic as well, we are working together as a team to try to understand how this condition that's affected the whole world particularly affects people with type 1 diabetes. So as a team, as we go into this new year, I hope that the JDRF and researchers continue in our commitment to work together for the betterment and people who live with the same condition the three of us have. And I think that's the way forward as we're starting to talk about things like advocating for vaccine priority and doing research to understand how this affects people with type 1. So to the two of you and to the larger JDRF, thank you for being part of the team that improves the lives of people who live with type 1.
Well, and thank you, Justin. I know when you began this work, you probably didn't know what a huge impact it was going to have on this conversation and on the decision making that we would be making. Thank you so much, because truly without your study, we wouldn't have as compelling data to be pointing to in this vaccine prioritization conversation. So we're so grateful to you and your team for all of that work that matters so much. And at the end of the day, the type 1 diabetes community matters so much to us. This is why we hope that this information has been super helpful to you all out there listening. I hope it's brought some clarity, and we just want you to be safe and be healthy, and I hope that this will help inform that. So thank you so, so much.
Yes.
Thank you, guys. Bye, everyone.
Thank you. And just as a reminder, jdrf.org/COVID vaccines, please check it out for all the latest information. And that page is being kept up to date in real time. This video is actually going to be available on YouTube and Facebook as well. So please feel free to share it with anyone who might have missed today's recording. Thanks again, everyone. And I hope you guys have a wonderful night.
Bye, y'all.
Bye. Thank you.